Hello, thank you for tuning in. I'm Raju Ramesh, consultant orthopedic surgeon and the innovator of Torbay Charts patient decision aid. I've created this brief presentation for EPIC team. I have divided the presentation into 5 segments and will give an overview of the concept of shared decision making and how Torbay chart differs from other PDAs. Being an orthopedic surgeon, I will be focusing on high volume, high expensive surgical activities like joint replacements and bring in the concept of actively involving in the patient in decision making process and thus giving control to the patients. So what is the problem I'm trying to solve and why does this require to be solved? Osteoarthritis is a very common problem. 1 in 6 adults in UK have osteoarthritis. I'm sure someone in your family, your friend or your neighbor would have hip or knee arthritis. In UK, over 8.6 million people have hip arthritis and knee arthritis is far more common than hip. The National Joint Registry showed over 220,000 joint replacements were performed last year, costing over 1.77 billion to the NHS. However, over 15% of the patients are not happy with their knee replacement. A study that analyzed the appropriateness of knee replacement in US showed that potentially over 1/3 of patients are offered joint replacement surgery inappropriately. There are numerous guidelines and clinical decision support to help making the correct decision. However, these are squarely focused on clinicians. Even the NICE guideline, which is directed to people with arthritis, does not lay the information in a format where a non-medical person could easily understand the nuances of choosing the right option. How could this be solved? Liberating NHS white paper document published by the Department of Health in 2012 suggested that the patient should be involved in decision-making process. No decision about me without me was the mantra. Various organizations like GMC, NICE, NHS England, King's Fund all endorsed this. This concept was then subsequently cemented by the Montgomery verdict in 2015. There are numerous studies that show that when shared decision making is conducted well with a PDA or patient decision aid, there is a significant decrease in the uptake of more expensive treatment like joint replacement. SDM also assesses the readiness of patient for surgery, and when done well with a PDA, the patient reported outcome measure scores improves well as well. Patient decision aid work like a Rosetta Stone, translating the medical jargon into simplified information repository. Whereas the clinical decision support tools are for clinicians, patient decision aid is for patients. They form two sides of the same coin. It allows the patients to make informed decisions in collaboration. Having said that, I present to you some of the PDA tools that are available. The more recent PDA tool produced by the NHS England in association with Versus Arthritis is really nice and comprehensive, but it is not practical to be used during consultation as it lacks granularity in suggesting which treatment are appropriate for that person sitting in front of you. What do I mean by that? Here, the pros and cons of various treatments and their odds of success are displayed, but it does not help the patient to consider the treatments that are appropriate for them. One may think that all treatments are available and appropriate. This is where Torbay Charts patient decision aid comes into play. The panoramic drone view gives a roadmap into an intuitive infographic sheet. Information here is arranged in multiple layers. Patient can choose stage-appropriate treatment. Combinations of treatments can also be selected. And like as one would do in a comparison website, they can compare two treatments side by side. Any local resources or exemplar treatment from a hospital can be included in the decision aid. A multi-language module is also possible. Patients present at different stages of disease. Whereas knee replacement can be considered for a patient B and C, it is inappropriate for patient A. Moreover, patient C may choose not to have a joint replacement even though that option is appropriate for them. Thus, Torbay chart allows clinicians and patients to explore these options better. Torbay chart is being used in the Torbay Hospital for over 5 years. Our pilot study demonstrated that 93.5% of the patients felt that shared decision-making consultation occurred when Torbay chart was used. Over 50% of the patients who came into the ESP interface, that's extended scope physiotherapy interface, still chose non-operative treatment. The clinicians felt that the consultation was focused. Very importantly, 5.6% of the patients who came in expecting to be listed for joint replacement chose non-operative treatment. Based on the volume of patients our ESP sees in a year, it would mean around 90 less patients would be referred for consideration of a joint replacement. At 2-year follow-up, these patients showed that the decision was still sustained in 1.9% of the patients, which meant that on an average, we would be avoiding joint replacements in nearly 30 patients every year in our trust. This would save over $250,000 for our trust alone. Translating this to the NJR would mean that over £35 million with a conservative estimate of 2% reduction will be achieved. In a small-scale extension of the pilot to the neighboring trust, we found a very similar effect as well. In another trial, in a PCN network, we found that the onward referral for knee replacement was only 8.1%, and nearly 75% of the patients chose non-operative treatment. How can this concept of Torbay charts used in collaboration with Epic? Torbay chart could feature in the patient experience module and could be part of the referral pathway integration. I'm sure this will enhance the patient experience when they can explore various options, compare them, discuss with family and clinicians before choosing the one that fits their need best. There are various benefits when a good shared decision making is conducted well. Everyone benefits from this: the patients, the clinicians, the hospitals, and of course, the insurance companies. A significant reduction in costs as well. Where does Torbay chart sit in relationship to other PDAs? In our opinion, Torbay chart is very well positioned for ease of use during the consultation, and with its layered approach, it stands apart from the rest of them. And it is also reasonably well priced compared to the others. Torbay chart is not limited to hip and knee arthritis. It can be used in any condition which goes through stages, and more complex treatments are considered in sequence. It is best administered after a diagnosis is made. For example, knee pain may be referred from hip arthritis, and not all shoulder pains are due to frozen shoulder. Non-orthopedic conditions like stress incontinence of urine, treatment of menorrhagia, stress management, diabetes management, etc. can all be developed. Here are my contact details. Thank you for listening.